Well, good evening, everybody, and welcome to tonight's webinar on improving health outcomes by incorporating HPV self-collection. My name is Angela Heathcote. I'm from Eastern Melbourne PHN, and we thank you for joining us for this evening's webinar. I'd like to start tonight's session with our acknowledgement of country. Eastern Melbourne PHN acknowledges the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands our work in the community takes place. We also acknowledge the lands on which you may be dialing in from tonight. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders past and present. MFN is committed to the healing of country, working towards equity and health outcomes and the ongoing journey of reconciliation. We also recognise and value the knowledge and wisdom of people with lived experience, their supporters and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. So just a little bit about our agenda today. We have three main speakers with us tonight. We have Dr. Rebecca Starkey, who's going to go through the main facts and what you and your patients need to know about HPV self-collection. We also have Dr. Dan and Anna joining us and bringing it all together in general practice and talking about their time working together on self-collection quality improvement activity. We're also going to show a short video which demonstrates the localised cervical screening pathways for GPs through Health Pathways Melbourne. And at the end of tonight's session, we'll provide an opportunity for question and answer with all of our speakers. So in summary, tonight's presentations will be covering these main learning outcomes for you, comparing the options for cervical screening to support your patients to make an informed choice, discuss clinical situations where self-collection can and cannot be offered, apply appropriate guidelines when following up people with positive HPV results, discuss the potential for HPV self-collection to engage those who are under or never screened into the National Cancer Screening Program, identifying patient cohorts for screening and implementing processes to meet practice quality improvement goals, and lastly, but not least, identifying relevant health pathways relevant to this topic. As mentioned at the end of the session, so we'll do it at the end of the session and not the end of speakers, just so that we can keep to time. We'll actually run a Q&A session. You'll see at the bottom of your screen an option for clicking on the Q&A. If you do have any questions throughout each of the presenters, please pop your questions in there and we'll endeavour to go through all those at the end of tonight's session. We'll also be running some poll questions through Rebecca's presentation, which is a great interactive session. It's a great way for us to be able to gauge your thoughts and ideas across the content as we're presenting on that. These will pop up on the screen as we go through and we'll give you some time to answer those questions, and we'll also show the results of those as we go. So I'd like to introduce our first speaker for tonight, Dr. Rebecca Starkey. Rebecca is a general practitioner and clinic owner in Melbourne, actually in our Eastern Melbourne PHN catchment. She's also the academic coordinator of the teaching and learning team in the Department of General Practice and Primary Care, and has a background in research, completing her PhD before becoming a GP. She has a particular interest in women's health, providing cervical screening education for primary care as a medical educator with the Australian Centre for the Prevention of Cervical Cancer. We're very lucky to have Rebecca tonight. So I'd like to pass on to Rebecca now and her team for presenting. Thanks, Rebecca.
Thanks, Angela. Thank you for that introduction. And thank you everyone for joining us tonight to discuss this really important topic and learn more about it. And I think it's really exciting as GPs that we can make such a difference in this area. So it's really good that we stay abreast of all the latest changes. So just to tell you a little bit more about myself, as Angela mentioned, I'm a GP in Bundoora. So I'm at a really long-standing, well-established GP clinic. It's only a small clinic. There's 5 GPs. We also have a registrar and Melbourne University medical students with us. We have a couple of nurses and usual administration staff, so practice manager and very long-standing reception staff. So we've been there for over 40 years, so our client base is really well established. And I own the clinic along with one of my colleagues who also works there. So I'd like to move on to the acknowledgement. So Angela, thank you for that acknowledgement of country. I'd just like to acknowledge the Wurundjeri people of the Kulin Nation, whose lands I work and live and play on, and I'm Zooming from tonight. So we'll just give an overview of what I'm going to talk about tonight. Tonight we're going to discuss the goal of elimination of cervical cancer. However, to reach this goal, we need people to undergo screening, and self-collection, you'll see, can help us achieve this goal. So self-collection offers choice to people about how they can be screened for cervical cancer and can also help address inequity. We'll discuss what you need to know about self-collection to support your patients to make an informed choice about screening options, and including when self-collection can be offered. So just for the next slide, in recognition that cervical cancer is a preventable condition, in 2020, the World Health Organization launched the global strategy to accelerate the elimination of cervical cancer. So the goal is to reduce rates of cervical cancer to less than 4 per 100,000 women in every country within the next 100 years. So Australia has answered the call and has set targets above and beyond the World Health Organization targets. The next slide. And in Australia, modelling suggests that we can achieve this target by as early as 2035. And sometimes with my patients, when I feel it's appropriate, I'll mention this target. And I think it's very helpful when I talk with patients about screening, is educating them that cervical cancer is a preventable cancer. However, screening is a really important part of that process. So in the response to, previous slide, sorry, Hannah. Oh, I've got a different one. All right, so Australia's vision, this one. In Australia, where I love this vision, and that's why I included this statement in it. It's a great vision. So in Australia, where preventable cervical cancer is a disease of the past, in which Australia's diverse communities have equitable access to information and to culturally safe and inclusive vaccination, screening, and treatment services. So in Australia, our goal is to have screening accessed by all populations. Priority populations have been identified as important to target for screening, including Aboriginal and Torres Strait Islander people, culturally and linguistically diverse people, LGBTIQ+ communities, and people with a disability, and people living in rural and remote areas. So data shows that Aboriginal and Torres Strait Islander people are more than twice as likely to be diagnosed with cervical cancer and more than 3 times as likely to die from it. So in Australia, the inequities in cervical cancer and survival are in part explained by inequities in participation in our screening program. Cervical cancer rates are higher in communities in remote and very remote locations, and survival rates are lower in lower socioeconomic status populations. We need to increase screening in these populations to address inequity in this country. It is recognised that underscreening is a risk factor for cervical cancer, with over 70% of cervical cancer occurs in people who are underscreened. So this highlights the importance of screening. So how do we increase screening for cervical cancer? This brings me to a campaign that is being launched in September. It's a cervical screening and self-collection awareness campaign is going to be launched. So this campaign will be the largest cervical cancer screening campaign in 20 years, and it is expected to drive patient demand for screening, particularly for self-collection. So tonight we want to arm you with the information so that you're ready to assist people in making their choice on how they choose to be screened. So self-collection offers a key opportunity to expand screening. So research has shown that self-collection is highly acceptable. It increases autonomy and control, provides empowerment. It's quick, easy, it's convenient. There's no pain or discomfort. It's private, and there's minimal embarrassment or shame. So self-collection can increase current screening rates, in particular in underscreened and never screened people. So what is self-collection? We've discussed why we need to screen for cervical cancer and that self-collection can increase screening, but now we'll discuss the what. So self-collection basically is a vaginal swab. So it involves taking a swab from the vagina using a simple swab. It provides an alternative to the clinician-collected test, which is a speculum examination, which is required for the traditional cervical screening test. So on a self-collected swab, the lab can test it for HPV. However, it cannot be used to perform cytology. For my patients, I'll sometimes use the analogy of COVID. I've found that patients are used to the concept of swabbing their nose or their throat for the COVID virus, and they can then understand or liken it to taking a vaginal swab looking for the HPV virus. So who can a self-collect be offered to? It can be offered to anyone who is requiring a HPV test. So that includes people who present for their routine 5-yearly screening test. So if they present saying, I'm here for my pap smear or my cervical screening test, they can be offered a self-collect. Also for people who are having their 1-year follow-up after being detected for HPV non-16-18, provided they had low risk, low-grade cytology or a normal cytology, and also 1-year follow-up after a normal or SIN1 colposcopy. So just bring your attention to the cervical screening pathway. I'm not sure how many of you are familiar with this pathway, but I do encourage you to have this resource bookmarked. It's available on cancer.org and it's very useful. But on this slide, I know it looks busy, but by the end of tonight, we'll be a lot more familiar with this pathway. But on this slide, I've just pointed out where self-collection can be offered for screening on this pathway. So starting up the top, it can be used there when people present for their routine screening. And also, if we follow down the yellow pathway in the middle, which is the intermediate pathway, they can, when they presented their 12-month follow-up, if they tested positive for HPV non-16-18, they can be offered a self-collect there. And at the 2-year follow-up as well, they can also be offered a self-collect if they prefer. So who cannot be offered a self-collect? So patients who require a co-test cannot be offered a self-collect test. So a co-test is the test for HPV and for cytology. So people who require a co-test are people who present with symptoms. So if someone presents with unexplained or unusual vaginal bleeding, particularly post-coital bleeding or persistent unusual discharge, they require a co-test. Also, patients who require a test of cure. So patients who have previously had a high-grade change or on their colposcopy, for instance, currently they require a test of cure, which is the co-test. This space is going to be changing shortly, and I will talk to that more shortly. But also women who have a history of adenocarcinoma in situ, they require a co-test and DES exposure in utero. So before offering self-collection, you need to exclude on history that they don't have any symptoms and they don't have any high-grade history that requires them to have a co-test. So it is important to take a good history when your patient presents. And for checking history, don't forget you can use the National Screening Registry, Cancer Registry, to check your patient's history if they're not sure of their history, if you don't have it there on file. And you can link your electronic health record to this registry for easy access. So I mentioned before there's some upcoming guideline updates. They haven't been published yet and we're not exactly sure when they're going to be released, but it will be soon. So I just wanted to allude or discuss them now so that you're aware that these changes will be coming. But these updated guidelines basically will recommend that a test of cure can become a HPV test. So that means self-collection, when these changes come out, will be an option for people who are completing a test of cure. So when those details are published, you'll be able to see them on the Cancer Council Australia website, and the program will be updated, so you'll be able to see those changes. But basically, they're going to increase the availability of self-collection at various stages along the cervical screening pathway. So there'll be more opportunities in which you can offer your patients self-collect, or they can opt to have a self-collect. So supporting your patients to make a choice. How do you collect, or how do you instruct your patients on how to perform a self-collect? So the most commonly used device for a self-collect is your red-topped blocked swab. So they're the 552C or the 552C.8. So it depends on your pathology provider. So this swab is either delivered dry to the lab, or it's resuspended in a thin prep file at the time of collection. And then the thin prep file is then delivered to the lab. If you send your swab dry to the lab, and your lab requires this swab to be suspended in a thin prep file, most situations that lab will forward the dry swab onto a lab that does the testing on a dry swab. But basically, it's important to check that you've got the correct swabs. And my advice is that you check with your local pathology lab as to whichever lab you choose. Give them a call, or your practice manager can, or your clinic nurse, and make sure that you've got the right swabs. Your lab will provide you with the swabs, and they're free of charge. And they often come with a handy patient handout to explain to them how to collect the test. It's also important to note that the samples don't need to go to the lab immediately. They don't need to go each day. For most labs, the samples can be processed for up to 28 days after they've been collected. In my clinic, the samples are collected every 2 or 3 days. Self-collection is easy to do. This is an example of the material provided by the laboratories about how to do a self-collect. This one happens to be from the Victorian Cytology Service. In my practice, I show this to the patient so they can make an informed choice about whether they want to be screened by this method or prefer a clinician-collected sample. So the self-collect is a vaginal swab. There's a red line on the swab that shows the patient roughly how high to aim to insert the swab, but it's basically the length of their index finger, and encourage them to rotate it for approximately 10 seconds. This handout is available on the Australian Centre for Prevention of Cervical Cancer website in several languages as well. Okay, so in terms of setting where self-collection can be performed, all cervical screening, including self-collection, needs to be ordered and overseen by a healthcare professional. So doctors and nurse practitioners can sign the pathology request form under the current MBS rules. However, your primary care nurse plays a really important role in discussing the testing option with patients and also educating the patients on how to collect the sample. So if patients are with you in an in-person consult, they should be encouraged to collect the sample while they're still at the clinic, as it is thought more likely that the sample will actually be collected then and there, rather than if it's taken away. However, the sample can be collected in any setting that you feel it is appropriate. So in the context of a telehealth consultation, or if a patient prefers to collect it at home, they can collect it at home. However, instruct them, it's important that they remember to date the sample, because it might be different from the date on which you requested the sample be performed. So the dates might differ and the lab might get a little bit confused. The healthcare professional is not required to observe the patient collect their sample unless the patient prefers you help them. You can take them help a vaginal swab if they want you to. So if someone with mobility issues, they might prefer a self-collect because they might want to avoid a speculum examination, but they might want your help to do the vaginal swab. So, and just remember that even if you help them collect the vaginal swab, it is still a self-collect because it's been taken from the vagina. It hasn't been sampled from the cervix. So it is still labelled as a self-collect on the pathology form. Okay. So now we have a poll question. So this is Jan. Jan is 40 years old. Just move that. She has no symptoms. So she has no abnormal vaginal bleeding, no postcoital bleeding. She has no past history of a high-grade cytology. She was last tested 12 months ago and she was HPV non-16-18 detected. She had normal cytology. Prior to this, her previous tests were negative for HPV. The recommendation after a test last year was to repeat in 12 months. Can Jan be offered a self-collect? Okay. I think everyone's put in their answers. Does that look like, Angela?
They have. Does it come up on the screen?
Yes. Okay, yeah, there it is. Sorry, it was hidden for a minute. Okay, so the answer is yes. And so good. And most of you, 81% of you got that one right, so that's great. So yes, Jan can be offered a self-collect at that 12-month mark because she was non-16-18 positive and she had normal cytology. Okay, so supporting your patients to make a choice. We'll just go into a little bit more detail now, what you and your patients need to know. So there is some concern amongst some clinicians that self-collection is not as accurate as a clinician-collected sample. However, research shows that when using PCR technology, self-collection is just as sensitive as clinician collect in detecting HPV. This was found in the Arbon 2018 study and the 2020 SCOPE study by Marion Savelle. This next slide just shows these graphs are from the 2018 Arbon study, and shows the accuracy of self-collect HPV samples compared with the clinician collect. So the self-collect is in the purple in the graphs and the clinician collect is in the yellowy orange. So on the graph on the left, this shows samples collected using tested with PCR, comparing, whereas on the right, those samples were tested using signal amplification. So this demonstrates in that graph on the left that if PCR is used, a self-collect sample is just as sensitive as a clinician-collected sample in detecting HPV. So because of this, it is mandated in Australia that all self-collect samples are analysed using PCR, so you can be reassured that a self-collected sample is just as accurate as a clinician-collected sample. Self-collection is safe. So there are also some concerns amongst some healthcare practitioners, and also I find with patients more so, that a sample taken incorrectly will not find HPV and therefore present as a false negative. I have had many patients request that I collect the sample, and they'll often state because that way they know it's done correctly. They're worried that they will do something wrong and that that the test won't be accurate. However, in the lab, there are safety controls on the HPV test to ensure that samples taken incorrectly are reported as unsatisfactory rather than as a negative. So firstly, there's the cellularity control. So this is a specimen adequacy control and indicates that there was adequate cellular material in the sample to ensure that the result is valid. So importantly, if HPV is not detected, you can be certain that this is a true result from a representative sample. And if the patient has not taken the sample at all and returned the swab, it will give you an invalid result. There's also assay failure control. So this ensures that there's no inhibition of the PCR reaction. So if there's any interfering substances such as lubricants or creams or large amounts of blood or discharge, and if it interferes with the sample and with the testing, you will receive an unsatisfactory result rather than a false negative. So the rate of unsatisfactory test results is low. It's around 1 to 2% on self-collected samples. So back to our patients, and you help them compare the options before patients make a choice. It's important to compare the advantages and the disadvantages of both methods, particularly when it comes to the follow-up of results. So on this table here, we have clinician collected and we've got self-collected. So both tests will identify HPV infection. So on a clinician collected sample, it will detect HPV in the cervix, whereas in a self-collect, it's going to be detecting if HPV is present in the vagina. And I'll often explain to patients, if there's HPV in the cervix, it will shed into the vagina and it will be picked up. A difference between the two samples is that you cannot do liquid-based cytology on a self-collected test, whereas you can on a clinician-collected test. That's a key difference between the two. Approximately 90% of your cervical screening tests will come back negative for HPV. And for both options, whether it's clinician collect or self-collect, the patient is to return in 5 years' time. Approximately 2% will be positive for HPV 16 and 18. And again, for both methods of collection, the advice is to refer for colposcopy. Approximately 6% will test positive for non-16-18, and this is where the tests differ. If the sample was collected by the clinician and HPV non-16-18 is detected, then the lab will then go ahead and perform the liquid-based cytology on that sample. However, if it's a self-collected sample, they cannot perform the cytology because there's no cervical cells collected, and the patient has to return. I think it's really important to explain this to patients because I tend to find women who are, or people who are particularly busy and time poor, at that point when I explain that step to them, they'll say, oh no, I just want you to collect it now. I do not have time to come back. Whereas other people who are very keen to avoid the speculum examination will say, that's okay, if it's positive, I'll return and I'll deal with it then. So it's an important difference in the two sampling techniques to explain to participants. If the sample is returned as unsatisfactory, then if it's clinician collected, the patient's instructed to return in approximately 6 weeks' time, so there's time for the cervical cells to regenerate. However, if it's a self-collect, they can repeat that test at any time that suits them, anytime they can. Now, likelihood of return. So this shows the chance of your patient having HPV non-16-18. And you can see it varies depending on age. So overall, the rate is 6%. However, it's the younger age groups that are more likely to have a HPV non-16-18 detected compared with the older population. So supporting your patients to make a choice, other points in the pathway where self-collect can be offered. So patients can be discharged from the cervical screening program with a negative test between the age 70 to 74. So for any patients in this age group, it's important to note that if any HPV is found, whether it's non-16-18 or 16-18, it is recommended that they are referred for colposcopy. So for this age group, self-collection makes an excellent choice, as there's no need to return for a second sample, even if HPV types other than 16-18 are found, because they will all be referred for colposcopy. And I find this age group can find speculum examinations particularly uncomfortable. And just back to our pathway. So just to familiarise yourself a little bit more with this pathway, the green section is the low-risk pathway. So they're patients who have presented for their CST, they've tested negative, so they're low risk and return in 5 years unless something changes in the meantime and they have some developed symptoms. But the pathway in the middle is the intermediate risk pathway. Self-collection can be offered. So if a patient it tests positive for non-16-18 on their test, they go down the intermediate risk pathway, they return for cytology for a clinician collected sample if it was a self-collect. And if it's low risk, the cytology is negative or low risk, they return in 12 months' time for a repeat test. They can be offered a self-collect at that point in time, and also at the 2-year follow-up as well. So Jan is here at the 12-month follow-up on the intermediate risk pathway. I'd also like to point out here, at the 12-month follow-up test for non-16-18, 60% will again test positive at this point in the pathway at 12 months, and they'll need to have a cytology test. So it's a good idea to discuss this with patients when they return at the 12-month follow-up, so they're aware that there's a fairly high chance that they'll need to return for a clinician collect if they do opt for a self-collect at this point. However, this population will go straight for colposcopy rather than return for cytology if they test positive again. So these are people, I know, so it's a little bit small, but it's also written up there in bigger writing there on the right. So if a woman is over 50, if she's Aboriginal or Torres Strait Islander, or people who are overdue screening by at least 2 years, if they test positive at this 12-month follow-up, then they go straight for colposcopy rather than returning for cytology. So this population are a good group to offer a self-collect to in the 12-month mark, because regardless of the result, they won't necessarily need to return to you for a clinician collect. Likewise, at the 2-year follow-up, anyone who tests positive with any HPV will go straight for colposcopy. So this is another good group where self-collect is a good option. Keep in mind the lab will advise you on the management for the patient based on the result. You do not need to remember this pathway. However, I do find it useful to have an idea or a good idea of the screening pathway so you can advise your patient when they're with you on the possible outcomes of their test. Okay, so back to Jan. So we have another poll question. So we have identified that Jan can be offered a self-collect. What is the chance that she will again test positive for HPV non-16-18 and need to return for cytology?
Just give it a few more seconds.
Yeah, we're getting there. I think some are thinking a little bit harder about this one.
I think we've stopped there. I'll share the results.
Yes, please. So 60%. So the majority of you got that right. Well done. So she's at that 12-month mark, and it's 60% chance that she will again test positive for HPV and need to return for cytology. So very much letting her be aware of that at that point when she presents, so she can use that information to decide whether she would prefer to do a self-collect or clinician collect at that point in time. Okay. So in summary, self-collection is accurate, it's convenient, it's acceptable, and can improve screening in underscreened and never screened people, thereby improving equity. Okay, so we'll bring it together now doing a case study to try to reinforce our learning, and there'll be some more poll questions. So this is Lauren. Lauren is 29 years old. She's pregnant. She's never had cervical screening and she's anxious about the process. She has no symptoms. So poll question, can Lauren be offered a self-collect? Getting there. Most of you have answered.
I think we've started to share the results.
Yep. So yes, fantastic. Most of you got that right. Yes, Lauren can absolutely be offered a self-collect. Okay. Next slide. So poll question. What are some of the things you might want to discuss with Lauren to help her make sense of her choice? So one, self-collection is just as accurate as a clinician collected sample. There's about a 4% chance she'll have to return for liquid-based cytology. There's about a 17% chance she'll have to return for liquid-based cytology. If she doesn't do it right, she could get a false negative result. I think we're slowed.
Can you see that there, Rebecca?
Yes. Yep, I can see that there. Okay, so a little bit of a trick, that one, but most of you chose the correct options. So for this particular, there's two that are correct. So self-collection is just as accurate as clinician collected. Yes, so that one was correct. The next one that was correct was there's a 17% chance you'll have to return for LBC just based on Lauren's age group. It's not 4%. 4% is more the older age group. And if she doesn't do it right, she could get a false negative result. That one is incorrect. She won't get a false negative result. She'll get an unsatisfactory result if she doesn't do it right. So if there's not enough cellular material or there's something interfering with the test, she will not get a false negative. She'll get an unsatisfactory. Okay. Next slide. So poll question 5, is this allowed by Medicare? Most of you have answered. Yep. Share results. And yes. Yes, this is allowed by Medicare. Okay. So back to Lauren. You're pleased to see that she's done the test as required and she dropped it in. The result is HPV non-16-18 positive. So what is the correct follow-up? Return for a co-test in 1 year, refer to colposcopy because she's never been screened, or return for cytology. Good. So most of you, just over half of you got that one right. She needs to return for cytology. So she's HPV non-16-18 positive. It was a self-collect, so now we need to do the cytology to see whether she has a normal cytology or a low grade or low risk. Okay. Now, next question. What do you talk to her about? Are we on the same screen there? What do you talk to her about to get her? No, sorry, I skipped forward. So Lauren returns for a speculum exam and you obtain a sample for cytology. Her cytology results are normal and she's recommended for a repeat test in 1 year. She comes back for an appointment for a postnatal check a year later. You mentioned that she's due for her 12-month follow-up test, but she's again anxious and reluctant to have a speculum examination. Next question. What do you talk to her about to help her choose this time? So one option, she can't self-collect as her last test was abnormal, or she can self-collect. If HPV is found, she'll go for colposcopy. Or the third option, she can self-collect. There's a 60% chance she'll need to return for cytology. Nearly there, I think. Yep, okay. So it's a tricky one, this one. She can self-collect. However, if HPV is found in this situation, she'll go for colposcopy rather than return for LBC. And that is because she was late to the screening program. I'll refresh your memory on this next slide. So we're back in this orange, yellowy orange intermediate risk pathway. Lauren actually falls in this square here because she was 2 years late for her screening. I think she was, from memory, I think she was 29. So she was late to the screening program. So she was over 2 years late. So therefore, if she tests positive for it again at that 12-month mark, she's actually referred for colposcopy rather than needing to return. So in this situation, the self-collect was a perfect option for Lauren because she was reluctant to have the speculum examination. And regardless of if she tested positive again, she was going to need to go for colposcopy rather than return for a clinician collect. Okay. So I just want to finish up by bringing to your attention some resources that will help you in your practice that you can refer to. We'll send you an email, I believe, after this webinar with these resources, so you'll know where to find them. But information from this presentation has been brought together in this resource here, which is available on the Australian Centre for Prevention of Cervical Cancer website. And on this nice table, it brings together a lot of the information. So it's a worthwhile one to have available or bookmarked. Same with this, the next one, the Cervical Screening Pathway Quick Reference Guide. It looks a little bit daunting, but it is a really useful resource to have available, just so you can discuss with your patients when they're with you and they're making a choice on which test they'd like to have. It's helpful for them to know the possible outcomes of the results. So as I said before, the lab will tell you in the results the recommendation, but sometimes it's nice to know before you get the result what the possible outcomes might be for that patient so they can make an informed choice. Also, there's these resources for Aboriginal and Torres Strait Island people. There's videos, there's different languages. They're really great resources. I encourage you to have a look. And there's also resources for culturally and linguistically diverse people. And you'll find resources in different languages. And that's it. Thank you.
fabulous. Thanks, Rebecca. Lots of fantastic resources and information there. And yes, after tonight, today's presentation, and then the following few days, we'll put these all together to share with all attendees. And I think everyone will be interested after Dan and Anna's presentation, who I'm about to introduce shortly, to view our Health Pathways presentation, which actually brings all these tools and resources together in one spot for the clinical teams. So what I'm going to do now is I'm going to introduce our next speakers. So I'd like to introduce you to our next speakers, Dr. Dan and Anna, to present on their journey together in increasing cervical screening rates at Dr. Dan's clinic. I apologise. Dr. Dan is a general practitioner and member of the College of, my notes have been covered over and I do apologise. There we go. Dr. Dan is a specialist with the Royal Australian College of General Practitioners, having graduated with honours from Monash University. As a practice owner, he is deeply committed to the education of future medical professionals, actively teaching medical students from Monash University and supervising registrars. Additionally, Dr. Dan serves on the subcommittee of the Eastern Palliative Care Clinical Governance Committee and participates in the fracture diversion program with Eastern Health. I'd also like to introduce you all tonight to Anna Peters. Anna is a final year medical student who's completed a 6-week research placement at Dr. Dan's Medical Clinic in Monbulk earlier this year. Her interests include women's and children's health, clinical reasoning, and using research to improve patient outcomes. She's hoping to pursue a career in general practice, and we're hoping that Dr. Dan has convinced her, or also emergency medicine. So I'd like to stop sharing my screen and pass over to Dan and Anna. Welcome.
Thank you so much, Angela.
Thank you.
Firstly, I wanted to thank Rebecca for that wonderful talk and such an informative presentation regarding cervical screening. And I really wanted to begin by also thanking both Angela and Ray Lee from the Eastern Melbourne PHN for all their hard work and working so cohesively with us. In particular, Anna for her time and coming this evening as well, and all the attendees, along with our wonderful team of staff that have done an incredible job in what we're just about to present and the process of improving outcomes for patients. So thank you very much for your time, and I'll start by a little introduction about our little clinic. So we're a little clinic, town of Victoria, which is a beautiful little town that I'm passionate and in love with. We've got a really passionate team that work cohesively, and our real goal is good patient outcomes. So where this actually started is we really wanted to reassess our performance in cervical screening and see how effective we were in doing that over a period of time. So fortunately for us, over many years, we've been entrusted to teach students, and like Anna, who have worked beside us in actually doing some research in the general practice setting. And then are able to give us an idea of how we're progressing with cervical screening. Now, I do apologise firstly because there is a humour element in this. I have made some very interesting slide transitions in tribute to my children, so please bear with me. All right, so why we discussed and why we actually wanted to do self-collection. So we opened our clinic day one of lockdown one. So that had its inherent challenges. And basically, we had a very good team, and we've always had a very good team. So during that time, we had to function for quite a significant proportion of that time with me being the single male doctor, which clearly has its inherent complications and barriers, in particular to do with cervical screening. So we had to think of ways to improve outcomes and manage. So what we wanted to do, especially when doing a project of this magnitude and trying to improve our assessment of how we're progressing and also include patients that are appropriate. The key is, as your clinic, and that's what I'm hoping to bring tonight, the things that you can do is try and pick a cohort that you want to actually screen. So we started by the hypothesis of who is likely to be underscreened, what groups are likely to have been delaying their sort of testing, and look at ways that we could actually bring those patients in and improve the level of our screening of those that are eligible and do it over a prolonged period of time to lead to a good endpoint. As I said, I apologize for the animations. So now this is a really fundamental element that I wanted to talk about. And this statistic is by Eastern Melbourne PHN. And I currently understand that only 35% roughly clinics are actually connected to the NCSR. And the National Screening Register is such an important facet in us being able to identify who's actually due for testing, those that actually need to have further investigation, and is a good way to objectify the data that you're actually having in your clinic, which may or may not be accurate versus the national data. And that really leads to better outcomes. So first and foremost, if there's only one thing that's taken from my little moment here with Anna as well, is I'd really love you to invest some time in connecting to the NCSR and also being able to get your clinical software to communicate to the NCSR, which will actually improve the way that patients are managed, flowed, and how your staffing can then assess who needs appropriate testing. So how do we connect? When this whole group of education seminars finish, and there'll be actually a toolkit that will be sent out. There is actually a guide within that toolkit that'll talk you through a little bit of how to connect to the NCSR. And I've got a slide coming on that will actually show you how to connect. And I'd really like everyone to look into doing that for their clinic, or if they're not able to do so, speak to someone who can. So this little slide talks about on Proda, where to actually go to and where you can click on in your Proda account to enable NCSR access. And then on the actual cancer screening register, you also need to add on your practice. For further information with that, the PHN has a great digital health team that can actually help you do that. So the next step with trying to improve outcomes and actually get a better outcome for the majority of your patients is engage the whole team. You know, we have teams of clinics depending on the size of the clinic. And there are multiple members of the team that could actually be very helpful, be it reception, management, nursing teams, students, registrars, other doctors. The key is with anything that improves patient outcomes, you need people that are really passionate, and their priority should be improving that patient outcome. And if you include the right group, you will achieve your goal. So the implementation of self-collection. Now, Rebecca did allude to this as well. So it's actually very, very straightforward. So when the PHN brings out the toolkit as well, it'll help you. As Rebecca rightly said, you can speak to your pathology provider. But the other thing that's really helpful is VCS actually do collect from clinics, even if you aren't linked to a pathology provider. They will supply you the kits for free. They give you mailing satchels to help you mail out your actual tests. And as Rebecca said, these tests remain stable for a significant period of time. So it is something that even in a smaller clinic, you can actually implement without significant cost burden and will improve patient outcomes. I also see that basically, especially in our clinic, I can see that self-collection actually makes it a lot easier because it actually will help break down some of those barriers to having a full cervical screening test when potentially they only need to do a self-collection. So the key is education, educating your team, educating the staff, sharing tasks and actually sharing the workload so that not one person's carrying it all the time, and cross-checking. So we as a clinic actually cross-check every single patient to ensure that it's correct with the NCSR and our actual patient data, that we're collecting the appropriate test at the time. And that actually saves patients coming back and forth for unnecessary appointments. So with the importance of NCSR, Anna, who I'd mentioned before, she's finally a medical student who did a research project with us at the start of the year, prior to us engaging with Eastern Melbourne PHN and doing this project. So Anna discovered some really good highlights looking at raw data. So she didn't look at our polar data or any already entered information. She actually looked at the whole patient cohort, and she did a wonderful job. So I'll just hand over to Anna at the moment. Thank you.
Great. Thanks, Dan, for that introduction. Yeah, so as mentioned before, I spent 6 weeks at the clinic earlier this year doing a quality improvement project focusing on cervical screening. And my two aims with the project were to get a really accurate and up-to-date record of screening rates at the practice. And then I also had a look at what the impact of self-collection was at the clinic, particularly for groups of patients who might be under-screened. So to do this project, I manually went through all the NCSR data for about 500 patients at the clinic. And there are a few advantages to doing that. First of all, it's the most accurate data that we had compared to what was on best practice. It also meant I was able to get a list of women who were overdue for their screening and hand that over to the clinic staff so they could then follow them up. The other thing I was able to do as I was collecting the data was see, women who hadn't been screened for years or sometimes decades, who had been caught up over the last 2 years of their screening with the introduction of self-collection. So that was really encouraging to be able to see. And as the data came out, I could see that the clinic was doing a really good job. They had about 85% of the eligible patients at their clinic were up to date with cervical screening, which is obviously a really good result. There were a few under-screened groups, so younger women, the 25 to 29 age group, and then the older postmenopausal women were, a bit less screened than women in that middle age range. However, when we looked at self-collection, we found that self-collection was really, really good at addressing that disparity and catching up those under-screened women. So on the whole, 75% of women were taking up self-collection when they were offered it. But in the under-screened groups, that number rose to 87%. So what my project found was that self-collection was really effective, particularly for catching up those under-screened women. So overall, it was a really positive result, really valuable project to do.
Thank you so much, Anna. And we really enjoyed having Anna there. And it was nice to actually see that we were actually achieving something. And in particular, in that under-screening cohort, which Rebecca might agree with this as well, they're the ones who are often missed. And it's such a simple thing to implement that can actually lead to a very meaningful outcome. And we have actually had quite a few pickups that have needed follow-up. And I'm glad that we implemented this process. So the outcomes and what we've learnt. So this was actually really interesting. So obviously as a clinic and as a team, we'd worked well together and managed to do okay, really. But the actual impact of us working with Anna as well and looking at raw data was that when you do involve people at care, when you do look at the NCSR and you look at how you can break barriers and so on, the key that we actually learned was really important with regards to coding and data entry, so we could actually see objectively in future where our polar data was and how we're actually doing. So we'd done well by itself, but our data entry needed some work. One really good thing that you could also do, and you could implement this being an RSEGP education activity, is certainly if you do this type of project, analyzing how you're going as a clinic or as a clinician and looking at how you could be improving outcomes, it can certainly be a measuring outcomes CPD type activity that you could report. And I understand that that's something that a lot of college fellows are struggling with, the measuring outcomes CPD points. So that is something that you could certainly look at, and it actually has a meaningful outcome. So really, as I said, we've learned to break some barriers. We've improved patient screening, and in particular in those under-screened populations that wouldn't have happily gone to do their cervical screening had it been a conventional smear. we've learned clearly that if we do implement or import data appropriately into our software, we can actually see some good polar outcomes, which means that we get actual data that's easier to extract rather than doing what Anna did manually, which was an incredible job. And so therefore our next key step is working on data entry. And I just wanted to add one final little slide regarding where you can do that. So in software, there is actually a little data entry section. There is a linking area, which Angela will talk through in her next talk next week as well. But there are ways that you can actually add the data into your software. So it actually links, and then therefore you don't need to go back to first principles. Mind you, I do think it was so useful that we did go back to first principles because it highlighted for us as a clinic, this was something that we could actually work on. So I wanted to thank you for your time, and questions, as Angela mentioned as well, will be at the end, but happy to discuss things with you at that time. Thank you.
Thank you so much, Dan and Anna. It's a great presentation and a great outcome. And the one thing that Dan didn't say is that their screening rates are now at nearly about 90%. He's nearly reached that target, haven't you? So it's a great achievement. I'm just going to share my screen, and what I'm going to share with you all now is just a short 5-minute video, which is an introduction to Health Pathways Melbourne and the cervical screening pathway. There was a lot of information that Rebecca provided us all in her presentation. So this may be a great resource if you're not already using it to go to keep all that information together in one spot for you and help with your clinical guidelines and decision making as you go through with patients.
Welcome to Health Pathways. Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways Melbourne provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. This presentation will demonstrate how to access and navigate Health Pathways Melbourne to find relevant pathways pertaining to tonight's subject. Navigating Health Pathways. Visit the Health Pathways Melbourne website and log on. Here you'll find the homepage with the latest updates as well as pathway updates. You can search for the relevant page by using the search bar located at the top of the screen, shown here, cervical screening, or by using the table of contents down the left-hand side, shown here with women's health, gynecology. Today we'll be looking at cervical screening. Firstly, on the page you'll come across the background section, which provides the clinician with additional information, specifically shown here with information regarding the National Screening Program. As we navigate further down the page, we'll come across the assessment section. This section provides clinicians with a simple list of steps that they may consider taking to diagnose and evaluate the severity of a patient at the point of care. Drop boxes throughout the pathway provide supplementary information, which I can show here with checking previous history by checking the register. Check the routine screening recommendations according to the National Cervical Screening Program. And here's information about the new program, which provides the option for self-collection. Self-collection test. Further information, and at the point of care with your patient, you can provide them with some instructions. As we continue further down the page, we'll come to the management section. The management section provides a succinct list of steps that clinicians may consider taking and includes additional information needed to execute these steps and links to referral options. This section also provides relevant extended information the clinician may wish to consider, shown with self-collected CST results, referrals to non-acute, As we come further down the page, we'll come to the referral section. Today, we'll be looking at the non-acute gynecological referral, which will take us to this referral page. This section includes locally relevant requests and referrals that the clinician may request from a third party for their patients. Here we have public. Specifically, we do have the statewide referral criteria, shown here, with the inclusion and exclusion and required information required for endometriosis. As we navigate further down, it will remind us to check the Safer Care Guidelines. Location specific for our region at Eastern Melbourne, we'll find a list with all the service-specific criteria and information required for the referrer. Further down the page, we do have a private section, which provides a list. Returning to our original pathway, at the very end of the page, you'll find the information section, which provides a list of selective links to useful information specific to health professionals and patients. This slide provides a list of relevant and related pathways and resources for improving health outcomes by incorporating HPV self-collection. Some of these include cervical screening, which we navigated this evening, gynecological referrals, and also highlights vulnerable populations. To access Health Pathways Melbourne, go to the website address at melbourne.healthpathways.org.au. It's available to general practice teams and other clinicians in the Eastern Melbourne and Northwestern Melbourne PHN catchments. If you don't have access yet, you can just scan the QR code there or send us an email through to info@healthpathways.org.au.
So we come to the last part of our session tonight, which is on the question and answer. Now, we've only got one question in the chat at the moment. I'll just give everybody a moment to, if they've got any questions, just to pop them in the Q&A. But the first question we have is actually for the PHN. So sorry, Dan and Rebecca. And the question that's come through is that does the PHN have someone who can support further with connecting with the National Cancer Screening Register? Because we've tried a couple of times with no luck. So by all means, if you can please send your requests through to digitalhealth@emphn.org.au, so through to our digital health team. We do have one of our team members, Tara, who is fabulous at connecting through to PROTA, and we have since discovered with Telstra Health recently that through all the practices doing My Medicare registrations, that has alleviated some of the barriers that people have found through trying to connect to the National Cancer Screening Register as well. So if you are connected to My Medicare, there may be some steps that have been actually solved for you, but by all means, please reach out to the PHN. If there's no other questions, I'm not sure if Dan or Anna or Rebecca have any further comments before we finish up for the evening. No? So I would like to, Dan alluded to this just earlier in his presentation, that we are running the second part of our webinar series next week on Thursday. It's our Quality Improvement Lunch and Learn series that we've been holding each PIP quarter for practices. And this is for all of practice teams to come along. This session will outline some of the steps and practical tips and ideas to support your practice with implementing QI activities around the increasing of cervical screening rates and in particular focus on self-collection self-collection. So this is 12:30 next Thursday. So by all means, please pass on this information to your colleagues. We'll also be sending this out through our next MPHN newsletter next week, and also a reminder through our practice manager and practice nurse Basecamp platforms. As Dan also talked about, we worked very closely with Dan and his wonderful team at his clinic in looking at the steps that we are going to talk about at this webinar. And following the webinar, we're actually going to be releasing our quality improvement toolkit. So this toolkit is going to bring everything in the one spot, including things such as steps, how do you actually connect to the National Cancer Screening Register, how to actually upload your information into your patient records to have accurate and up-to-date records, and lots of other information in there around setting up your practice for self-collection and also addressing barriers for those priority populations. So watch out for this. We'll make sure that this is actually also released to the participants at tonight's webinar as well. So that'll be coming out probably towards the end of next week or the week after, so by the end of this month. Lastly, our colleagues at the PHN are also offering for general GPs in-practice training or online training for initial assessment and referral for mental health care training. This is something that two of our colleagues are working very hard on at the moment, and does provide an opportunity for further training for yourself. So please, if there's something that you're interested in, please register through the QR code or reach out to our team for further information. And lastly, as per usual with our webinars, we thank you for your time. As per usual, we like to try to improve and enhance our education opportunities for our practice teams out there. We greatly appreciate you spending just a moment to scan the QR code there to provide that feedback through our evaluation, and also give us some valuable insights into your thoughts around cervical screening and self-collection as well. And as mentioned through Dr. Starkey as well, we will be sending out an email post this webinar. This will come out to you in the following few days. We'll provide a copy of this webinar, also a copy of the presentations, and also relevant resources that the Australian Centre for Prevention of Cervical Cancer has provided to us. In a separate email following this, you'll also receive a certificate of attendance for tonight's attendance at today's webinar. For further information and support, following on for that question before, connecting to the National Cancer Screening Register, there are the details there for our digital health team. We also remember that your general practice team facilitators are there to support you with any support as needed, whether it be general practice support or support with quality improvement. And there's the information there for our Health Pathways team if you'd like to connect to Health Pathways Melbourne. So thank you everybody for your time tonight. We have finished the session a little bit earlier. We didn't have as much questions as we needed to allow for. So thank you for your time this evening. We'll let you get back to your evening, to your dinner and to families and friends. Enjoy your evening and thank you for joining us, and we hope to see you next week at our Part 2 webinar. Thank you very much and good night everyone.